Kathy.
Hello, everybody. How are you doing this afternoon? I just wanted to let everybody know that we're not going to go over RVU values and such. I'm just going to go over the new CPT codes that were added that CMS is going to allow. So I don't want anybody to think that they're going to get RVUs. So this is just my introduction and our agenda. We're going to do the G codes, and the new CPT codes, hospital nursing visits, and I'm going to go over a little bit about what the future is going to hold for us. So all information is current as of the time that I prepared this and presented it. And remember, CPT is a registered trademark of AMA, the American Medical Association. What is the proposed rule? So the proposed rule comes out every year, and it's changes that Medicare is going to make to their fee schedule. It includes new G codes that they're going to have for that year, and it also establishes additional payment policy to Medicare Part B payment policy. There is also a proposed rule for inpatient and then outpatient, but I just basically focus on the Part B. Basically, they submit their proposed rule in September. Actually, they submit their proposed rule in July, and they request written comments to be given in September, and then it's closed. And then in November, the final rule is released, and then everything goes into effect on January 1st of this year, 2019, unless it was actually stipulated that it's going to go into effect later. But nothing goes into effect prior to January 1st. We're going to talk about stuff that's going into effect on January 1st. This is the website where you can actually find this information if you want to look at it and read it on your own. There's a lot of information in the final rule. I'm still in the habit of calling it a proposed rule. It's not proposed anymore, it's final. So the first thing is documentation. G2012, it's one of our G codes that's coming out. And remote evaluation of recorded video and/or image submitted by the patient. So basically what this is if you have a picture of, say you have a lesion on your hand or a mole and you're not sure what it is, and you have a dermatologist that you deal with, or you have your primary care physician that you deal with, you can send a picture of that lesion to them. They can review it and make a determination as whether or not you need to come in and have it removed, or just monitor it. So, but it cannot follow, they have to give you an interpretation and a verbal follow-up, but it cannot, within 24 hours of receiving it. It cannot have originated from a related E&M visit, and it cannot result in an E&M or a procedure within the next 24 hours. So if it does, then it's bundled in. Now, the concerns are that we need consent from the beneficiary, and how should the consent be documented? There's a lot of things going on how they should do it and how the documentation should be done. My recommendation is that each individual office, if you're going to use this procedure, you need to have a policy on how it's going to be done. Do you want to just verbally document that the doctor received verbal consent, or document that a staff member received verbal consent from the patient? Do you want to email them a consent, have them sign it, and return it to you? There's a lot of things that each individual office has to decide. The pricing is going to be lower than an existing face-to-face E&M exam, and the frequency, how often can a practitioner provide this service? They're not putting a limit on how often it can be provided, but they are saying that it should be limited to established patients. and it's not going to be for a new patient. So you're not going to call a dermatologist that you've never seen and say, hey, look at this lesion. This is limited to an established patient. And it could be anything, not just pictures of lesions. It could be a recorded video of the way you're breathing and you send it to your pulmonary doctor, different things like that. So it is actually a good service for some patients who don't need to come in, but maybe their pulmonist wants to hear them breathing, and they could just give them additional medication, or if the lesion doesn't need to be addressed right now, they can just monitor it and look at it at the next visit. The other thing, how often can a practitioner provide this service? They're not putting a limit on it, but they are saying that they will be monitoring the utilization. So you want to be really careful and make sure that it's medically necessary and appropriate. If the patient has a concern about a lesion or something, you may not think it's a big deal as the dermatologist, but the patient does. So, and it may be something, if it's something that they would come into the office for, but you could do a picture, that's a service you may want to consider. G2010, brief communication technology-based service, virtual check-in by a physician or other qualified healthcare professional who can report E&M services. Basically, it's a continuation of the last one that we just, virtual check-in by a physician. So basically it's a call-in, a check-in to see what's going on with the patients. Services would not be subject to Medicare's telehealth restrictions. They need to be used to determine if office visit is required, and if the office visit results, it would be bundled in with the office visit. And it would be a 5 to 10 minute medical discussion. Okay, G0513 and G0514, prolonged preventative services. Okay, so this isn't a new code, but it's a code that they're adding to the list of telehealth services. Now, it's prolonged preventative services, and I still haven't been able to figure out what services it would be added to. I'm trying to check into that, and I can't specifically figure it out. The first thing that came to my mind was annual well visits, but annual well visits don't have a time documented to them. But I did read an article that was talking about if a patient comes in and you spend more time questioning them on what's going on. But at that point, are you on an annual wellness visit, or are you going to be billing for an evaluation and management service? So there's more to come on that. I'm going to do a little bit more research, but these two codes are going to be added to the telehealth list. So there are things that you can do telehealth. Telemedicine codes. Additional codes that are going to be added. 99452 and 99451 are two codes, are the top two codes in this service. Basically, what they are is interprofessional telephone, internet, or electronic referrals. So it's a communication between two providers. You know how your doctors pick up the phone, they call Dr. A calls Dr. B and says, hey, I have this patient, they have this condition, and this condition, and I'm a little perplexed because I'm not sure, this hasn't worked, and this hasn't worked, and we can't do this. So basically, physicians are going to get reimbursed for this service now. So Physician A is going to request an opinion and a care plan from Physician B. And Physician B has access to the patient's medical records, the electronic health records, and they're going to write up a report and send it back to physician A on his recommendations on how to treat the patient. 99452 would be the code for physician B, and it would be 30 minutes of his time. Now, 99451 would be the code for physician A, the doctor who's asking for the assistance. Now, some of the things that CMS was concerned about was who's going to benefit from this service. Is physician A going to benefit in his doctor knowledge, in his knowledge base, or is the beneficiary, is this for the sole benefit of the beneficiary? Or is it just something that they're doing that he wants to find out? It's a trial. If it's for the benefit of the beneficiary and it's going to benefit the patient or the beneficiary, then it's going to be allowed. Is it reasonable and necessary? Is this something that the physician A should have known, or is it outside of the scope of his practice and he's needing the consent, the recommendations of another provider? Consent from the patient. Because the patient's going to have the burden of care, there has to be a consent that physician A spoke to the patient, the beneficiary, and explained to them that he's going to go and he's going to get a consultation from his fellow providers, but there's going to be a charge. So the patient has to realize they're going to have a charge from physician A and physician B. Now, how are you going to document that consent? Basically, Medicare says that all you will have to have is the consent documented in the chart. But what you have to remember is you also have to have the beneficiary's permission to give their billing information to physician B's office so that they can bill for it. So my recommendation is that each office should sit down. If this is something that their providers do, and this is something that their provider wants to bill for, my recommendation is that each office should sit down and figure out how they're going to document this and where they're going to keep the documentation. And are they going to do a written, signed authorization, or are they actually just going to take a verbal consent and document it in the chart? And this is something that each practice has to take into consideration. You're also going to have to think that you're going to get a lot of flack. A lot of providers, when I presented this at a conference back in November, when it had just passed, what a lot of people said to me was, well, the patients aren't going to want to pay for this. We do this for them now, and we don't charge. Yes, providers do all these services. They call their patients. They look at things. But now Medicare is making it, giving them the opportunity to get reimbursed for it and taking some of the burden away from the providers, because they were burdened with doing this to give their patients good care, and now they can do it and give their patients good care and get reimbursed for it. But it's going to take a while for the patients to become adjusted to the fact that they're going to have to pay for it. It's going to take a while for the practices to get adjusted on documenting it and on getting the consents for it and how to bill it for it. So this is another code that can possibly be, if you're in a specialist or a primary care and they contact different specialists on a regular basis to get additional information on how to treat patients, this is a code that you may want to consider. And if you look at the list of codes again, you have 6 codes, and they're all different. They're all timed based. So remember, whenever you have a code that's time based, you have to have at least 50% of the allotted time. So if you look at 99452, that's at 30 minutes. So the provider has to spend 16 minutes on this, and he has to document how long he spent. And this would be between his time of talking to the other provider, researching it, looking through the patient's medical records, and writing up his recommendations. So you can look through your CPT code at this code range. These codes were all approved and added this year, and they are reimbursable by CMS. Now, I don't know what the other insurances are going to do. I don't know if the commercial insurances are going to cover all these codes. So that's something that you're going to have to find out. All I can tell you right now is that CMS is going to cover these codes. Chronic care management, remote physiological monitoring. So we have 3 codes for this, and one is for the initial setup and patient education on the use of the equipment. The next one is for the initial device and supplies with daily recording or programming alerts transmission, and this is for a 30-day period of monitoring. And the other one is the monitoring treatment management service, 20 minutes or more of clinical staff, physician, or other qualified healthcare professional time in a calendar month, requiring interactive communication with the patient caregiver during the month. So if something goes wrong, you have to contact the patient, then you would be using that last code, 99457. Excuse me, I'm sorry. No, these are not new CPT codes. This slide is labeled wrong. I'm sorry. These are codes that had been requested to put on the telehealth list. CMS, when the proposed rule, during the year, people write into CMS and they make requests on how they want to change codes and where do they want to put codes. So CMS received requests from patients that or from providers or stakeholders, as they call them, that 99221 through 99223 should be allowed on the telehealth list. CMS, after much investigation and responses from other stakeholders, determined that these services do not qualify for telehealth services. They believe that an initial hospital visit, when a patient's being admitted to the hospital or you're seeing them for the first time in the hospital, that this should be an in-person service. It should be a face-to-face service, and it's not something that should be telehealth. Subsequent hospital care. Now, right now, it says that they can be billed every 3rd day, and people requested that it be changed to daily, and Medicare, CMS determined that it can only be billed via telehealth every 3 days. So you're going to have to go in and see the patient once in a while. Subsequent nursing facility care, they requested a frequency limit, and that request was denied. And home visits. What was done is previously for a 99341 for a home visit through 99354, when you go out to see the patient, when the provider goes out to see the patient at the home, they have to document on the note why they went to the home and why the patient couldn't come to see them. So what they're doing is they're removing that requirement. So you no longer have to say double amputee, unable to come in. All you have to do is document the medical necessity for the visit, the same as you would for an office visit. So that burden has been taken away from the providers. They no longer have to do that. Bundling episodes of care for subsequent abuse, for substance abuse. So what the future has to hold, these are some of the things that CMS is thinking about doing, and they're asking for input from providers and from stakeholders. And anybody, a coder, I could write in what my thoughts are. Anybody could write in what their thoughts are. So the first question is, should they bundle the episodes of care? And there's different ways that they're looking at it. Is it going to be the psychotherapist, the medical assisted treatment, the substance, the psychologist, the hospital admissions, the outpatient services, what should be bundled and what shouldn't be bundled together. The other question is, do you think that bundling these services would help to avoid a hospital admission? And that's what their main goal is. They want to decrease prices and what they're paying out, but they want to be able to increase services and give the patients the best possible service. Substance abuse is estimated to be one of the highest charges that CMS is going to incur in the future. And they also want to know, should they allow incident to services when they're dealing with substance abuse? So these are some of the things that they're going to be looking at. So global surgery. Global surgery surveys. Remember last year, they talked about the global surgical periods, 10 days up to 90 days, and they were doing a survey. Basically, they had 7 states or 9 states that had to report the 99024 for every post-operative visits. Maryland was not included in that survey. It was Florida, Kentucky, Louisiana, Nevada, New Jersey, North Dakota, Ohio, Oregon, and Rhode Island. And every time they did a 99024 post-operative visit, they were supposed to send the HCFA form in. And then the RAND Corporation was doing an analysis on whether or not the patients were actually getting the post-operative visits that they were entitled to for each service. And it's all statistics, and as you're aware, where CMS can run any kind of statistics. So they ran reports on every surgery that was performed that was entitled to post-operative visits, and then they were trying to compare whether or not the post-operative visits were reported or not. Unfortunately, they got a poor response. So the results were inconclusive. They couldn't tell if providers were just not doing post-operative visits or not reporting post-operative visits or what was going on. So moving forward, the RAND Corporation is trying to come up with a different way to calculate whether or not the patients are getting the appropriate benefit. And one of the things that they're thinking about doing, CMS is, the reason they're doing this is they want to take the post-operative monetary value out of the global surgical value. So we really need to keep an eye on this. And if you're in a surgical practice and you feel that it's inappropriate for them to do this, that it's something that you might want to investigate and review with your providers, your practice managers, and respond to CMS on this issue and see exactly what's going on. Okay, the big topic that we had last year, CMS, just like CMS, they come up with something, they ask all these questions, and basically what they did most of the beginning of 2018 was they surveyed providers, they surveyed, they had several town meetings, several public comments, they had webinars, they had phone conference calls with providers, they received letters from different organizations as to how to change the evaluation and management documentation guidelines. What were they going to do? The medical necessity of the service is the overarching criteria for payment, so they want to make sure that they get the right information, but they're not sure exactly how to revise it. They're still not sure how to revise it. And when they came out with the proposed rule in July, what they said was absolutely different from what all the comments were. They basically said what they were going to do was they were going to take codes 99202 through 99204 05, and they were going to pay one fee, and then they were going to take 99212 through 99215 and pay another fee. And this was kind of the template that they told us that their recommendations were going to be. So a lot of people were up in arms over this because obviously if you're in practice, especially some of your practices that depend on what they get for their E&Ms, because that's all they do. Think about it. Endocrinologists, all they have is office visits. Some of your primary care, they live off of their office visits. So they can't afford to have their income cut, which is basically what CMS was proposing. And then there was additional G codes that they were proposing for severity. And I think when they looked at it, they realized that it was actually more burdensome. But this is not going away. They are adamant that they're going to continue with this process. They like this template, the way they're doing it. But the one thing they're talking about doing that I've been reading is having 3 allowables. They would have an allowable for your 99211, an allowable for 212 through 214, and then a separate allowable for 215, and the same thing for your new patient codes. What they're going to do, I don't know. How it's going to come out in the end, I don't know the answer to that. But it's something that we need to keep an eye on. It's something that we need to think about for our practices and figure out how we're going to work around it. Do we write CMS? Do we go to our organizations, AAPC, AHIMA, American Medical Associations, your different societies for your specialists? They all wrote into CMS about this. I know at the national conference, it was the big buzz back in April or May, no, the regional conference in DC in August. That was all anybody was talking about, was these changes to the E&M codes. It's a big impact. It'll be a big impact on practices. And I think that anybody who's in practice management should think about how it's going to affect your practice and what you need to do going forward. You also have to think about your HCCs, your hierarchy conditional codings, with your diagnosis codes. Make sure your docs are getting the highest specificity, because we don't know which way reimbursement's going to go, and we need to make sure that we're prepared for it. We need to make sure that it doesn't hit us in the pocket and affect our practices. So basically, these are the goals of the E&M proposals are they want to reduce administrative burden. With EMRs, the doctors really are not re-documenting all this stuff. The EMR is doing it. And in my opinion, the doctors are getting credit for stuff that they're really not doing, especially in your history and your some of your exams sections. They need to focus on what is clinically relevant and medically necessary. So your providers need to focus on their assessments and their plans, their documentations, what they saw when they examined the patient. They need to be more clear with those details, and they need to remove redundancy in the E&M visit documentation. I mean, basically, when you're talking about redundancy, if the patient was in 2 weeks ago and they're coming in for a 2-week follow-up, why do you have to document the review of system, a complete review of systems again, past family social history again? Sure, maybe you want to know if they were here 2 weeks ago for a sore throat, does your throat still hurt, but do you need to talk about all the other stuff? But that redundancy is there because of our EMR systems, because the EMR systems, most of them automatically pull it forward. So you might want to talk to your vendors and see how you can avoid doing that, how you can only pull it forward when the doctor actually looks at it. Because these are the things that CMS looks at when they audit. The documentation is there, so they don't know if the doctor really did it or not. these are some of the things that you want to think about. These are some of the things that are going to come up in the future. There's changes every day. You want to make sure that you check your CPT book, check the codes that came out that you would use most often, check your specialty area. Basically, as far as the issues with the final rule that I was going to cover, that's it. I don't know if anybody has any questions they want to ask. If you want to chat something in real quick, we can do that. Or if you have our email address, you have my phone number, you can reach out to me and I'll try and answer any questions you have or get any answers that you need. I'm not seeing any questions, so I'm going to say goodbye. Have a great day. Thank you for joining us.